Now, I'll go to the third and last subsession of this presentation on outbreaks and outbreak investigation. The third part looks at investigating an outbreak. How do you investigate an outbreak? As a public health officer, you will be called to investigate a given outbreak of a known epidemic-prone disease or a new strange disease. How do you systematically go about doing this? This is going to be, we are going to talk about this in the last sub-session of this presentation. Now, there are about 12 steps. Now, these 12 steps, although they look distinct, they are interrelated to each other, and some of them cross over each other. You have to obtain initial notification of the outbreak. You have to initiate a response. Immediately you get the information, you have to respond very quickly. You have to verify the diagnosis. After verifying the diagnosis, you have to confirm the existence of the outbreak. Is it an outbreak, or is it a case of wolf? And then you have to identify and count cases. You have to assess the local response. You set up immediate control measures. You address the resource gaps. You describe the outbreak. You formulate and test hypotheses about what caused the outbreak. And then you write the report and you disseminate it. And then you strengthen your surveillance. You be on your guard, because where outbreaks occur, you are likely to get other outbreaks. Now, we shall briefly go through each of these 12 steps. 1, initial notification of the outbreak. We said we receive, first of all, we know about these outbreaks from astute observations. We need observant people using the case definitions to see these cases. And then we receive this information from various sources. Some of them are formal surveillance systems that we've put in place in the health centers through the reporting systems, the information systems, but others are informal sources like community resource person, community leaders, parish leaders, and all that. Every rumor must be investigated. I have to repeat, for us to effectively prevent the deleterious effects of outbreaks, we have to investigate every rumor. Now, step 2, after getting the initial notification as the epidemiologist or public health expert, you have to assemble a team. You have to set up an initial response, and this involves assembling a team and preparing for an initial field assessment visit as soon as possible. You need to put together a cross-disciplinary team depending on the issues you are dealing with. If it is a suspected outbreak of a deadly infectious disease, you may need to get some laboratory technologists on the team who know how to collect samples for deadly infectious diseases. If it involves complex social issues, you may need to get an anthropologist or a social scientist or a social worker on the team. You may need to get clinicians on the team who will look out for clinical signs and symptoms, either clinical officers or medical officers. And for some outbreaks like nodding disease, you need experts, neurologists, and people who are experts in those conditions, pediatricians and others. So depending on the condition, you put together a team, and then you assemble the necessary logistics, including fuel, including transport, including supplies, including the equipment and the outbreak investigation kit included, which should be prepositioned so that you don't have to buy the kit at that time, but you pick the kit and you move. And then you also alert the district authorities or whoever is above you that I am going down to take this particular action. Now, with regard to logistics, I have to mention that it is not as easy. In many bureaucratic systems, you write a requisition, and then the intermediate supervisor signs, and then the top supervisor signs, and then sometimes they query it several times, and it keeps going around, and you answer the queries. Then after that, it has to go to prepayment audit. After that, they write the check. Then they look for 3 signatories. Then after that, they go, then they draw the cash. By that time, the outbreak might have ended. So that's a challenge. So you need systems that can bypass some of these processes, but maintaining accountability, because outbreaks also denote politics and resource issues, so we must be accountable. And then also, the first responders, your outbreak response team, must be appropriately trained, either before the outbreak occurs, or if you've not trained them and you find yourself you haven't trained them for that particular incident, you do what we call just-in-time training. Just-in-time training. Now, the third aspect is to verify the diagnosis. First of all, what is the diagnosis for this disease? There have been, in the immediate aftermath, they will tell you people come like this. Then they may add other additional things that may be people who believe in a certain faith, who come dressed like this. So verify. Look at the clinical findings. Talk to the patients carefully if it is a very deadly disease. Talk to the clinicians who examine these people. Examine some of them while reassuring the patients. And then you may take samples for laboratory confirmation as soon as possible for diseases that need confirmation. Not all diseases require lab confirmation. Choose a working case definition. So after looking at all these, develop a working case definition. But you know that we look at sensitivity and specificity. Is it able to detect those with the disease? And lastly, try to establish the index case, the first case that was affected by this outbreak. It usually holds a lot of information on how this story began. I always give the example of the Ebola outbreak in Bondibujo, where the first case was a male, which is not uncommon. The first case for these deadly epidemic-prone diseases is oftentimes a male. And this male had visited relatives in the Congo and then came back with some game meat, which included monkey meat. So that is, the index case might be difficult to establish. They may die well before the rest of the outbreak. But you need to find them and investigate them because they are an encyclopedia of what might have happened before, but also the new contacts that need to be traced. So you establish the index case and the contacts, and then you verify the diagnosis. Number 4, after verifying the diagnosis, this is the diagnosis, this is the case definition, this is the working case definition. Then count the cases. How many people fit that case definition? And then is the threshold exceeded? For measles, have you exceeded 3 cases coming from one parish? For Ebola, is there a suspected case that meets the definition? For meningitis, do you have 5 cases in a low endemic area? So do they exceed the threshold? So you confirm that the threshold has been exceeded, and once it is exceeded, you identify, try to find those cases wherever they are. There are some who would have been discharged, bring them back. Others have already died. Go and count the graves. So you have to count the cases because you will not get the attack rate without finding the total number of new cases that occurred. So you count the cases. So you use the working case definition and you start with the index case. Look for cases. But also we collect usually additional information on each case to help us to characterize and describe the outbreak. We usually collect information on age. Age is very important because certain outbreaks attack certain ages. Nodding disease is mostly in young people. Certain diseases like Ebola are mainly in energetic people who are walking and moving and linking with other people. And then sex is also important. Certain outbreaks are more preponderant in certain sexes. And then tribe is important, depending on behaviors of certain tribes related to certain outbreaks. The date of onset, the outcome, either death or cure, or they are still continuing on treatment. Complications that arose from this, we usually collect that information. And then exposure risk factors. What exposures, what are the risk factors that they have? Did they eat some game meat? Did they eat some sweet potatoes? Did they do this? Did they wash their hands? So we collect that information. Now, constructing a working case definition. To construct a case definition, we use simple objective criteria. If you use complicated criteria, the case definition will be difficult to apply. So we get simple but objective criteria. we develop a case definition using symptoms and signs. I also have to include signs. Signs are the things you find on physical examination. We may use laboratory results, affected population, the person, the location, that is the place, the time frame. We balance between a loose, sensitive case definition. If it is loose, it's very sensitive, but we are likely to get everybody. Or a tight, very specific case definitions. Now, we use these symptoms and criteria smartly to construct a case profile from that is increasing in specificity from a possible case to a probable case to a confirmed case. Or probable sometimes is called a suspected case. So we construct that gradient. I'll give an example here. Hepatitis A confirmed case, is a person who is found to have anti-hepatitis A virus immunoglobulins. So the antibodies are there against hepatitis A virus, showing that they had a recent hepatitis A virus infection. While a possible case is a person who has jaundice, that is the yellowing of the eyes, or an elevation of certain liver enzymes, a certain liver enzyme, which is called alanine transferase, ALT. Now, a suspected case is any two of the following: abdominal pain, fever, nausea, anorexia, and malaise. Any two, a combination. Why we do that is to increase the sensitivity. While why we go upwards to probable and confirmed is to increase the specificity. So the suspected case is usually at the working level, but we may need to layer other additional information to make it more specific. Now for Ebola, we have a proven or confirmed case where you isolate the virus and you see it under an electron microscope, or you use antibody tests, what we call the immunofluorescence assay, and you detect antibodies to Ebola virus in those concentrations, 1 to 64 parts. Then that is a confirmed case. But a probable case is a person living in an area where someone died. So you see, the definition includes someone dying. So someone first dies suddenly of Ebola, and then a person living in that area with more than 2 of the following symptoms: headache, fever, abdominal pain, nausea, vomiting, and bleeding. So someone died in the area due to Ebola, and then someone comes and says, I have a headache and fever. Now, if someone has not died, that might be malaria. But if someone has died due to Ebola, you may need to step back and then, So any 2 of those: headache, abdominal pain, nausea, vomiting, bleeding. And then a possible case is a headache or a fever longer than 24 hours where a person has had contact, in a person who has had contact with a proven or probable case. Now, it's important to balance the sensitivity and specificity of the case definition. A very sensitive case definition may bring in a lot of false negatives, and a very specific case definition may bring in a very sensitive case definition but with a low specificity will bring in a lot of false positives, while a very specific case definition but with low sensitivity will bring in, you will miss so many cases, false negatives. So we have to balance. If it is very sensitive, you may overload the health system, and if it is very specific, you have the danger of missing some cases. I would like you to take some time on your own and look at some of the case definitions at different levels that are used for these epidemic-prone diseases: polio, measles, cholera, Ebola, we have just talked about it, and bacterial meningitis. Now, case definitions are not cast in stone. They can be changed according to the locality and the nature of symptoms. A good example is for Ebola. The natural history of the disease has been changing. As Ebola, when Ebola had just attacked learned to attack human beings, it was very virulent and it used to cause a lot of bleeding, profuse bleeding from all body orifices. And the case fatality rate used to be 100%. But as Ebola has learned and adapted to human beings, it is learning new ways of survival, and it's getting a little bit milder. So the bleeding may not be very manifest. It could be small bleeding in the eyes, which you see as small red patches in the eyes, or bleeding, small spotted bleedings under the skin, unlike the profuse bleeding that we used to see when Ebola was still a very new disease. So the case definition can be changed depending on the nature of the symptoms. Now, you can also create new case definitions. Like, if we look at these three examples, try to imagine the case definition. An outbreak of sudden alcohol-related illness and deaths in Zone X. How would you construct a case definition for that? Probably a person, so it has to be a person, coming in with sudden collapse, loss of consciousness, vomiting, probably diarrhea, but with a strong smell of alcohol, and with a history maybe of having spent a night in a certain pub X, or even having taken, the relatives or caretakers tell you that they took a certain potent wine or type of alcohol. So you can manufacture that. So think about a case definition for dysentery and another one for food-related illness in a certain village. Now, still under this same intervention, we have to line list the cases. A line list is a rectangular database in form of a spreadsheet, and it provides a summary of key data about the cases in an outbreak. Each row represents a case. Each case takes a row, and each column represents a variable of interest that we would like to assess. And usually the first column is an identifier, a code, either a name or initials or ID number. And a line list can be paper-based, but it can also be electronic, where you enter it in a computer. And it should be easily accessible and quickly reviewed and updated, not very complicated. These are some of the variables that we take from the case report form and put in the line list, like identifying information, demographic information, clinical information, what are the signs and symptoms that they came with, risk factor information, what are the risk factors for the outbreak, for the case, what are do they manifest some of the risk factors? Then reporter information, who is reporting? And then sometimes we put the contact information, sometimes. Either their own contact or the contact of their significant other, so that we can quickly communicate whatever is happening with the patient, but also we try to find the cases, we try to track those who were exposed to the infected person. Which variables do we include in these case reports? We include components of the case definition because we need to record that they had fever, they had diarrhea. We include the case name or a unique identifying number. We include the date of symptom onset because it helps us to assess how the illness unfolds, how rapid it unfolds. Usually we include age and gender. And we may include other relevant demographic variables like race and occupation and other relevant risk factors. This is an example of a line listing of cases. As you can see there, there's a column for the case number. That's the unique identifier. And we give each case a unique number, the date of symptom onset. We said you can put some symptoms, like there they've recorded diarrhea, vomiting, they've recorded fever. And then the labs, maybe what did the labs find, the lab tests. And then some demographic information, age, gender. We may even include their village of origin. We may include their tribe. So depending on the outbreak. So that is that step. Now step 6 is to assess the local response. Remember, for the first steps, we have dealt with the immediate danger of the outbreak. The first 5 steps. We are trying to say, is there an outbreak? Are we sending a team? we line list, we find cases, we get a working case definition, we develop all these urgent issues. Now the next thing is to look at the systems issues. The systems issues. How is the local response? We have to set up an incident command center that coordinates the different actors, especially if it's a very big outbreak. Outbreaks are political. Different stakeholders may come in, World Vision, Red Cross, Ministry of Health, district local government, World Bank, Oxfam, they are all there. But they need to be coordinated. And there needs to be someone in control. So we have, you as the epidemiologist or public health specialist, you have to set up an incident command center that maintains and coordinates the different actors. They meet regularly to share information. We have to establish a communication office that maintains situational awareness to avoid, first of all, misinformation. There can be a lot of misinformation in outbreak situations. We have the information system also helps us to avoid panic. If you don't communicate, you can create panic, but also you can create distrust. We establish a district-level task force and allocate them their responsibilities, communicate clearly, including community mobilization, information, education, and communication. And the task force can include politicians, civil society organizations that are involved in the response, and the district health team. And we allocate responsibilities depending on their expertise and areas of emphasis. We ascertain the number and type of personnel, as well as the logistics available for case management, the drugs, the medical supplies, the guidelines. In some outbreaks, like in Sierra Leone, Ebola outbreak, they had to do a sudden increase in capacity by doing rapid trainings because they didn't have the personnel, by importing technical experts from, we had the 200 experts from Uganda here, from our own School of Public Health and alumni, go in there. So that is called surge capacity. What is your surge capacity? The capacity to rapidly mobilize additional staff to respond to the magnitude of the epidemic. Staff, but also drugs, supplies, and guidelines. So these are some of the system issues. So the local response. Number 7 is to set up immediate control measures, because as you do these other administrative issues and the technical issues of confirming the outbreaks, other cases are being infected down there in the villages, but also in the hospitals with the patients in the isolation units. So you have to set up immediate measures to control the epidemic within the geographic area where it has occurred. And that is where Uganda departs from West Africa in terms of how they manage to control the epidemic. Uganda tends to succeed in controlling the outbreak within the geographical district or even sub-county where the initial cases occurred, while in Sierra Leone they got so many secondary point sources that led to a very complex propagated epidemic. So the target is to keep the epidemic confined to the geographical locus of the initial cases. So, how do you control? First of all, identify all suspected cases. Suspected cases, identify them. For less virulent diseases, like measles, cholera, initiate, like cholera and cholera, dysentery, initiate what they call barrier nursing. It's careful nursing where you reduce exposure to the patients so that it's not easy for health workers but also caretakers to be infected. And for more virulent diseases like the viral hemorrhagic fevers, you have to undertake isolation. So you find the case and the suspected case, take them away from their locality. Or there are so many human rights issues related to this, but for control's sake, you have to establish an ETU, Ebola treatment unit, and put these cases in isolation. And then, for contacts, those who are not cases, but they are contacts of affected cases, you have to trace the contacts. For less virulent diseases, provide them health education on how to protect themselves from infection, but also to monitor themselves for symptoms. But for very virulent diseases, we have to put the contacts under quarantine. So they are also removed and put in the unit, but in another area that it's not isolation, but it is called quarantine. And you wait for the entire duration of the incubation period, so twice the incubation period, to ensure that they've not got the disease, and then you can release them from the quarantine area. And then those who develop the disease, transition them to the isolation unit and then treat them there. And then you have to treat cases to interrupt transmission. So when you isolate people, don't just leave them there. You have to treat them to reduce mortality, to reduce complications, but also to interrupt the transmission of the outbreak. And then other control measures are like massive disinfection of fomites equipment, use of personal protective wear and personal protective equipment, including following strict protocols for application of these PPEs and PPWs depending on the infectivity of the agent causing the outbreak. For instance, for Ebola, strict guidelines for what to be put on, how you put it on, where you put it on. There is a donning room in the isolation center, and you move in one direction from the donning room. You are properly clothed from top to bottom, everywhere covered in material that is impenetrable by fluids. And then you move into the infective zone. And when you come out, there are procedures for removing in the doffing room. You are sprayed, all these measures, and then you remove in a systematic way. So these protocols need to be followed for different levels of infectivity of disease. And then look for the risk factors and address the risk factors, mass health education and targeted health education. Beware and target the many negative social behavioral practices that propagate the spread of the outbreak. You may need to do social distancing and make use of appropriate and innovative approaches for social distancing, like in Uganda, when we had cholera, where populations love to greet each other. You have to look for new ways of greeting, like exchanging a knock of the knuckles or a knock of the elbows. So these are innovations to try and maintain social connection but reduce infection. And consider vaccination or chemoprophylaxis, especially for high-risk groups like health workers and caretakers for patients, depending on the type of the outbreak. Now, in many outbreaks situations, this is what happens when we are not ready. We lose the opportunity for control. The primary case comes at this time. The first case at the health center comes at this time. So all through this time, these ones are in the communities. And then by the time we report this first case, it has occurred here, but this is maybe around day 5. The time we report to the district health office, it is day 13. By the time we report, the cases start to inflect and rise very sharply. We take the samples day 17, that is beyond 2 weeks. By the time we get the laboratory results, day 21, that is 3 weeks. And by the time we start the response, the outbreak is already controlling itself. And all those who need to have died, or those who need to have recovered have miraculously recovered. So we have a large opportunity lost for control. Now, this is what we want. Scenario 2. The first case comes at that time. We want to detect and report as soon as possible. We want to confirm the investigation as soon as possible before the graph begins to go up. We want to initiate the response as soon as possible as the outbreak starts to go up. And if we do that, then we have a large opportunity for control. So scenario 2 is the desired situation. Now, step 8, address the resource gap. We are still in the system issues. Address the resource gaps. It depends on the nature and the extent of the outbreak, as well as the capacity that you find at the district. You may need external resources to beef up what is available at the districts, including laboratory support, information, education, communication materials, specific infection control needs, like JIC, sodium hypochlorite, and protective wear, protective equipment, and vaccines. So investigation kits, beds, drugs, sundries, and all that. But you may also need just-in-time training to create what I call the surge capacity, to increase the capacity. Now, once you've done those administrative issues, remember we did the technical investigation to confirm the outbreak, then we did the administrative and system issues. Now you can start having a sigh of breath, of relief, but not yet, because you have to describe the outbreak. So you sit down now as an epidemiologist. You use the information that you collected about the condition and you analyze. Descriptively, you look at who is affected. When are they affected? How and where are these people affected? So you look at those factors and describe them. You get the numerator, that is the cases that we talked about here, the new cases, and the denominator, and you compute an attack rate, and it tells you, oh, how fast is this thing spreading to the population? You pose questions, and in addition to who, where, and when, you can ask why, how, and what. And you use appropriate tools to display the data, graphs, spot maps, determine the size of the population at risk using spatial and temporal criteria and relating them to how the disease is spreading. And then you calculate the attack rates, calculate the attack rate, and also what I talked about before, the case fatality rate. Time, place, and person, there are some tools that help you. Like for time, you draw an epidemic curve, and this can tell you how the cases increase in time, to know whether it's a point source epidemic or a propagated epidemic, and we can overlay additional information on when and where, when the cases occurred, to see how fast the epidemic is spreading. And then for place, we can use spot maps and shaded maps to show where the infected people are. And then for persons, we use tables of descriptive information to show who tends to be affected. What are the numerators and what are the denominators, and what do the cases have in common? This is an example for the Ebola epidemic in DRC that we are talking about. You can see the cases by sex, male, female, and total, and you can see that the females tended to be a little bit more affected than the male, and you can look at some of the factors behind this. We said usually the index case is a male, but because of the sick role and the role that women have in care of the sick in many rural African communities, then women become get extra exposure from these gender roles. And usually you have the third layer is the healthcare workers, most of whom are females anyway. So you then get in the healthcare workers. So these are examples of descriptive tables. Another descriptive table that is trying to show the distribution of cases that were an affected population. So, and this is an example of an epidemic curve and showing how cases kept increasing over time in this particular context. I think this was DRC to the peak, and then the cases started going down. The hospital itself that was initially affected was closed at some point, so probably that was one of the control measures. And then the curve also shows you those who survived during this particular outbreak and those who died in that outbreak over time. And you can see that as we go into the later stages of the outbreak, survival tends to increase, while in the early stages, almost all those who were affected died. This is an example of a spot map showing the distribution of cases by place. The distribution of cases by place. Now, after doing that, that was descriptive information. You now set up analytical studies. You formulate a hypothesis as to what might be causing this outbreak, and then you compare cases, that is the people who get the condition, and the controls, the people who don't get the condition. You administer sort of like a questionnaire and other tools, and then you compare through a case control study or other analytical studies. You talk to patients, you look for combinations or interactions of various factors, subject matter knowledge. So in the tool you include what you know about the issue, the known sources of this epidemic, the vehicles, the transmission routes, and then you talk to some patients, you look for outliers and all that. And then you can summarize your data in 2x2 tables with measures of association, like the odds ratio, to determine which are the factors associated. Now, in step 11, after all the analytics and that, you write your reports regarding the outbreak, describing the situations, the experiences, the answers you've obtained, the experiences in during the intervention, and then you recommend some priorities and control measures to be addressed. And you can also make conclusions about possible causes of this outbreak and how it can be controlled in the past. And you disseminate to those who need to know and those who need to act. And for some diseases, the country has international reporting regulations. You need to report to the WHO on certain disease conditions like Ebola. And lastly, strengthen your surveillance. Strengthen your surveillance because outbreaks may recur. The same outbreak will recur, and you need to learn from that particular incident so that you are stronger. You need to put in place mechanisms where the case definition is widely known. More people can look out for that disease so that when it occurs, it can be more quickly controlled. And you use that as an opportunity to strengthen surveillance for other outbreak-prone diseases. And then there are some special challenges in outbreak control. If outbreaks occur in certain complex settings, they can create a complex emergency where social determinants overwhelm control efforts. Look at the outbreak in West Africa. What factors do you think were at play in the mass propagation of this outbreak? Issues, among others, like spirituality, practices around burial and burial rituals. How do they treat the body before burial? How they need to do some ceremonies and cleansing of the body before they bury it, and how it was affecting people. Spirituality still, traditional healers. Many of these diseases, especially strange diseases, are ascribed to the spiritual in some of these communities. And they tend to go to the traditional healers where many infections, cross-infections occur, leading to propagation of the epidemic. The hiding of cases so as to conduct some of these rituals, the fear of going to isolation centers where they lose contact with their people. Gender issues and the sick role. What is the role of women in cleaning the sick person, in looking after the sick person? At times, almost a requirement for them in the society. The agency of the community to take action. How ready are they to take action to control an outbreak that has gone out of control? The human rights related to isolation and quarantine. You saw in some of these outbreaks in outbreak centers in Sierra Leone, some patients ran out of the isolation centers, ran to the marketplaces because partly of the isolation in the isolation centers and the loss of human and social networks and contacts. The awareness, levels of awareness. So we may need to teach people the very basic of how to deal with a certain outbreak. Like, for instance, Zika. the various ways in which it is spread, the mosquito and that, but also it's sexually transmitted. How many people would know that in a place where Zika has just occurred? And then normative practices around socialization. There are some societies where just the greeting is a heavy issue. They need to greet, they need to touch, they need to kiss, they need to hug in order to greet. So all these issues in combination could exacerbate the occurrence of outbreaks. Now, the last issue I wanted to talk about in this session is outbreaks provide a good opportunity for innovation. Epidemic response situations and the associated humanitarian emergency present opportunities where we can innovate and we can apply human-centered design to co-create solutions to several challenges. Examples of challenges for which we can provide solutions is extreme heat in Ebola treatment units. We can innovate around personal protective wear and personal protective equipment. We can innovate around diagnostics and case definitions, how to make them sharper at a cheaper cost, cheaper tests that have good validity, sensitivity, and specificity. As you know, how long does it take to confirm an Ebola outbreak? How can we simplify that? Innovations in patient monitoring technologies, especially for highly infectious diseases. These patients depend on resuscitation, IV fluids, monitoring of their vital signs, blood pressure, temperature, and pulse, yet we cannot get very near them because the more we get person-to-person contact, the more the risk of infection. How do we use new technologies to monitor their vital signs without being very near? Improving social distancing. How do we improvise to co-create around social distancing? Improving reporting and health information systems. How do we improve the movement of information? And I'll conclude this by showing one innovation that came out of some of the work that we did in our unit, the Resilient Africa Network, where we developed the EpiTent, which is a rapidly deployable tent for humanitarian emergencies in very hot, humid climate. And it reduces the average ambient temperatures in the tent structure by an average of 7 degrees centigrade, and the maximum temperatures by 9 to 12 degrees centigrade, using purely passive means, purely adaptive means, without air conditioning and all those other expensive sources of energy. So Outbreak, it goes to show that with collaboration, with human-centered design, with cross-disciplinary work, we can innovate around many issues around the challenges that we face in outbreak investigations. And this was under the Fight Ebola Challenge funded by USAID. Thank you very much for listening, and this is the end of the session on outbreaks and outbreak investigation.